And greetings, everybody. Welcome to the Research in Progress webinar series for the Robert Wood Johnson Foundation's Systems for Action research program. Thanks so much for joining us today. This is a reoccurring Research in Progress webinar series we do a couple times a month, providing an opportunity for our researchers who are a part of this national research program to share the work they're developing and conducting around how to better align and integrate services and systems that help to build a culture of health. My name is Glenn Mays. I'm a professor here at the University of Kentucky, where the National Coordinating Center for the Systems for Action research program is based. And I will be our moderator for today. Looks like we have a pretty good group of people joining us today as participants. I know we have a great group of speakers and discussants who are with us today. And so I think I know that you're really in for a treat in hearing about some new research that is teeing up through the Systems for Action research program. Just a few reminders. If you're joining us on the phone line, it's always a good idea to check and make sure that your phone is muted, so we're not hearing any background information or background noise. And also as a reminder, there is a web portion of today's call, and so hopefully you have the information on the URL link that you can click on and follow along, so you can actually you can have access to the slides that go along with today's webinar. We will be using the chat box feature as well of that the web-based portion of today's webinar. So when it comes time for questions and comments, we would love to hear your thoughts via the chat box. And so you should see on your screen in the lower left-hand corner of the screen the chat box there, and you'll be able to type responses in. And you actually don't have to wait until we get to the Q&A portion of today's call. If you want to type in your questions or comments as they occur to you, they'll be stored there for us. And then when we get to the discussion portion of today's webinar, we can get to those questions and comments. So I want to first step through a little bit of introductory material. First, again, our agenda today, you can see here on the screen. We'll be hearing from one of our newest research teams that is part of the Systems for Action research program, our colleagues at the University of Delaware, who will be presenting their research design and plans for the study you see here, implementing a culture of health among Delaware's probation population. We'll be hearing from Dr. Daniel O'Connor and his colleague Christy Visher. And then we're very pleased also to have commentary. Our discussant for today will be Dr. Michael Shafer, who is a professor at Arizona State University and one of the key leaders in our Systems for Action Collaborating Research Center that is based there at Arizona State University. So two key players today from our Systems for Action research program. One of our new individual research study leads based at Delaware, and then you'll be hearing commentary from one of our collaborating research centers based at ASU. Before I turn it over to our speakers and commentaries and commenters for today, I want to just give a quick overview for some of you who may be new to the Foundation Systems for Action research program. Just a quick overview about this program, this new research program, and kind of how we're organized to produce new evidence about systems and services research. Some of you may be familiar with our past work in the Foundation's past work in public health systems and services research, and certainly the S4A program builds on that work. The SRA program is really designed to help us identify mechanisms for aligning delivery and financing systems across sectors, across the medical care sector, the public health sector, and the broader social services sector and community services sector, with an eye toward improving health and well-being by aligning those delivery and financing systems across sectors. So the research that you'll be hearing about today, as well as the larger constellation of research that is happening through this program, is all testing novel mechanisms for alignment in delivery and financing of services that can produce a culture of health. And again, so a key piece of this research really is a key aspect of this research is the multisectoral, cross-sectoral approach. All the studies that you'll hear about today, as well as the studies that are other studies that are part of this program, are looking at ways of aligning and integrating activities across this wide range of sectors you see here. Certainly the health and medical care sector, but also thinking about the broader range of services and supports that produce health and well-being, transportation, nutrition, education, housing. As you'll hear today, importantly, the criminal justice and court systems as well that we know play key roles in health and well-being. All the studies are also, again, focusing on novel mechanisms for aligning those sectors and those systems, whether these are organizational mechanisms or financing mechanisms or information mechanisms, governance and decision-making mechanisms, workforce mechanisms. Lots of potential mechanisms come into play. And we need to be testing lots of different mechanisms to help us with this alignment, system alignment objectives. And so you'll hear some aspects from that today. In terms of how the larger SRA program is organized, I alluded to one key component already. Again, we have a coordinating center based here at the University of Kentucky that our role is to try to kind of develop and maintain the larger research agenda in this space, and to develop funding opportunities as well as opportunities for scientific collaboration and synergy across researchers who are studying issues around system alignment. We have also identified 3 collaborating research centers that exist across the country that are leading major components of the research agenda in S4A. Again, one of those collaborating centers is with us as a commentator today, the Collaborating Research Center based at Arizona State University. We also have collaborating research centers based at University of Chicago and based in Indiana at IUPUI. As part of this webinar series, you'll be hearing more about the research underway at each of those 3 collaborating research centers as well. In addition to those collaborating research centers, we also have at this point 4 individual research projects that have been funded through a competitive call for proposals process. And again, the research team at University of Delaware is one of those study teams leading one of those individual research projects that are just now getting underway. So so that's a bit about the larger structure for this program. And again, you'll hear more about the collaborating research centers, probably a bit about the ASU's collaborating research center today, but more about these centers and the work they're doing later on in this webinar series. So certainly stay tuned if you're interested to learn more about the research being pursued there. The slide gives a thumbnail sketch of the research priorities being pursued at each of the collaborating research centers, as well as our research that's being conducted here based in Kentucky. So more about that at a future webinar. So certainly stay tuned. I mentioned Delaware is one of the 4 individual research projects that have been selected and are now getting up and underway through the S4A program. The 3 other individual research projects you can see on this slide as well, based at Michigan State, Los Angeles Department of Health, and also Drexel University. So really a wonderful, very strong set of studies, cohort of studies that are starting up now in these areas. And again, you'll also be hearing in future webinars from these other individual research project teams as well about their studies that are getting underway. So with that, I'm going to turn it over to our presenters for today, and in particular Dr. Daniel O'Connell, whose credentials you see here on the slide. He's with the Center for Drug and Health Studies and a faculty member in the Department of Criminal Justice there at University of Delaware. And I know his colleague, Dr. Christy Visher, is also with us as well. So Daniel, please take it away.
Well, good afternoon, everybody, or morning if you are west of us. I'm Dan O'Connell, and I am a scientist at the Center for Drug and Health Studies here at the University of Delaware. I am here with Christy Visher, who is the director of our center, to talk about implementing a culture of health among Delaware's probation population. So this grew out of the Robert Wood Johnson Systems for Action, and the research areas, we're kind of addressing three, we think, of the four research areas that RWJ is sponsoring on this initiative. I've got them up there on the slide: investigating the implementation and impact of strategies to achieve alignment coordination across delivery and financing, reducing health inequities through cross-sector alignment and improvement, and investigating the effectiveness and efficiency of informing and decision support information and support strategies in achieving those things in community settings impacting diverse populations. So the way that translates into the Delaware Culture of Health Project, we're going to implement a local change team, which I will discuss in more detail in a moment. The numbers you see there reflect the research goals on the previous slide. So to coordinate the alignment, collaboration, and synergy across systems by providing health screening and linkage to care among Delaware's probationer population, and recognizing health as a holistic concern, not just focused on health screening and linkage to a medical provider. We've brought in a rather diverse and large team. It includes 9 agencies and health providers, and is designed to reduce the inequities through this cross-sector alignment and delivery improvement. Studies focus on probationers, and inclusion of community-based service partners investigates how information and decision support strategies, that's the change team, can improve health in community settings impacting diverse populations, in this case probationers. The fourth, incentives are not really a part of this particular study. So the problem that we're trying to address is a criminal justice problem. We have over 2 million people incarcerated in the U.S., and while that gets a lot of attention, there are almost 7 million people on probation, people who are under criminal justice care but who are still residing in the community. If you are incarcerated, the state is required to provide you health care. There is no such requirement to the probation population. Yet they face a lot of the same issues as the incarcerated population. In fact, often they're the same people, just at different points in their lives. And they definitely represent a traditionally hard-to-reach population. They tend to be minority, they tend to be young, tend to be undereducated and underemployed. So they present with a host of issues. One of the things we found when we were writing the application, actually, is just how lacking data is on the health issues of the probation population. We did find some research on it, and it indicates that, as you can see on the slide, anxiety and depression, asthma, sexually transmitted infections, all much higher than the overall population at large. Substance abuse disorders tend to present at 3 to 7 times the rate of the general populations, 12 times more likely to report past DNA treatment. Also much more likely to have received mental health treatment in the past. So they are at a heightened risk for a number of kind of mental health and substance abuse disorders, but also of more traditional health concerns, chronic diseases such as hypertension, asthma, cervical cancer. They presented, the lower number is incarcerated folks, but as I said, a lot of these are often the same folks, or at least the same type of individuals. I think I skipped a slide. Nope. So the problem is that health is not traditionally considered a responsibility of probation departments. Probation departments are concerned with maintaining security over the population, kind of keeping people in line while they're serving their sentence in the community. But they do not generally address health pretty much in any way from what we've found working with our local probation department here in Delaware. Yet it's a place where people gather on a regular and predictable basis. People are either seeing their probation officer, sometimes up to once a week, more generally once a month. People are showing up at a specific location where they are scheduling an appointment to meet with people. So they're spending time there. We have been many times to our local probation department, and there's a waiting room outside where people sit often for hours waiting for their an opportunity to see their probation officer. So we've kind of, in a way, got a captive audience that is in a location on a regular basis. The probation department can't really take on the health responsibility of screening. They don't have the funds. They don't have the person power. So to put somebody out there to do a kind of health screening is not something they can do. However, in Delaware anyway, they are willing to allow us to do this, to come in and access the population and to assist in any way they can. The local Delaware Probation Department, they've agreed to provide a space, a private office, and to work with the class, the folks while they're on site. So getting more local again, we've done some past research, and the Delaware DOC has some number on the local population. Again, 80% of people under correctional care in Delaware have a history of drugs and alcohol. Approximately 15% are mentally ill. A high number of dropouts and a low overall education level. And they also face these, issues we discussed: joblessness, job skills. Housing is a tremendous barrier for these folks. Transportation is a barrier. Only 14% of folks incarcerated in Delaware had a valid license when they went in. Incarceration severs family ties. And of course, there's the stigma of being involved in the population, in the criminal justice system. Referring really quickly to the family ties, Delaware works on a level system where folks who are incarcerated, their incarceration term is followed by a period of probation. So a lot of the folks that are on probation in Delaware are actually returning from institutions back into the community and serving part of their sentence on probation. So broadening out from the probation department to the broader systems at large, we have multiple issues, as I've discussed, that are impacting the health care of these folks, or the access to care among the probation population. We've got housing, we've got employment issues, substance abuse issues, just a number of different concerns, all of which are dealt with by agencies that are often siloed. They do their individual kind of area of concern, they do it well, but they don't generally talk to one another on a regular basis, and certainly do not talk to each other about providing health care to the probation population. So recognizing that, we know that to fully address the needs of this population, we're going to need input and collaboration among a diverse group of agencies and practitioners. So the model that we've chosen to kind of bring these people together and focus on an issue grows out of the NIATEX, the Network for the Improvement of Addiction Treatment. And NIATEX kind of uses this change team model, and what we're doing is a modified version of NIATEX. But the idea is to facilitate action across agencies and systems that overlap but do unique kind of things, as I discussed. They do things very well within their silo but not across. And what the change team does is bring people together, and there's a series of exercises. I'll go through some of them here in a minute. We do a number of team building exercises. We empower the team to create buy-in. And all of this is done to create a team that can foster change and innovation across domains and agencies. One of the things that change teams do, this is kind of the empowerment part, is they recognize that the expertise to address a particular area rests largely with the team. So the researcher or the NIATEX coach is kind of on the team but outside the team, guiding them forward, but allowing the team to solve problems and address issues as a group. We have worked with these models in the past, not on this particular concern, but where we've had not 9 players, I'll talk about the number of players in a minute, but where we've worked with agencies working together, and we found that using this method with like maybe 2 agencies trying to do things has been very effective. So we empower the team to do things, and we bring them together through these team building exercises. So what the change team is made up of, there are a number of roles that people have on the team. There's an executive sponsor that is over the overall project, if you will. And our goal here again is to provide screening and linkage of probationers to get them connected to healthcare. So the executive sponsor for this particular project is going to be a ranking official in the Delaware Department of Correction. He was actually going to be here today, but he's tied up in an all-day training that he could not get out of. So we were going to have Alan Gridstead, who is Chief of Community Corrections for the state of Delaware, is the executive sponsor on this project. Then there are organizational sponsors who are on the team representing each of the organizations that is at the table. So those are people whose role is similar to that of a CEO in a business, who can implement or at least cause to be implemented policy or procedural changes within their specific organization. So, for example, if the team finds that something needs to be done a little differently in housing, it's a person that has the ability to either do that or has the ear or influence on somebody who can get that change made. There's a change team leader or a coach in the NIATEX language that guides the team through the quality improvement process. For this particular study, that's going to be me. I've had experience doing this in the past, working with an HIV study as part of the criminal justice drug abuse treatment studies funded by NIDA. And then there are the team members. The team members, they're composed of the executive sponsors, organizational sponsors from each participating entity, and the change leader from Center for Drug and Health Studies. So the team will then implement the change process under the direction of the change leader. So here is a rather busy chart of what this kind of looks like. And what you're looking at on the left are the different organizations that are involved in the Delaware Culture of Health team process. So it's the Department of Corrections, because it's going to be their population, and the practitioner is going to be physically placed on site in one of their offices. The Department of Health and Human Services handles mental health issues in the state of Delaware, substance abuse in the state, and there's also the key link to Medicaid in the state. The Department of Housing will be here, the Departments of Labor and Education, so that people presenting with those issues will be linked to them to provide services. Christiana Care is the largest medical provider in the state of Delaware. They run our main trauma center. They also have family medicine clinics, HIV clinics throughout the state. The family medicine practice is actually two practices. The family medicine is the main one in Christiana Care, we think, for a lot of folks presenting with health issues, that we will be linking them they have 2 hospitals in the Newcastle County area, the main hospital, the Christiana Hospital. There's also the Wilmington Hospital, which is located in downtown Wilmington, an area from which many of the probation population is drawn. So they will, as we've talked to the folks up there, they're going to be the catchers, if you will. When we refer, folks will be getting to them for getting into care. The Department of Public Health is involved. They are largely interested in this for access to HIV testing and screening. Obviously, they work with DHS, so a lot of the other health issues will be there, but our health department is on board for doing that. Connections Incorporated is a local community-based substance abuse and mental health provider that provides outpatient treatment, again, with offices throughout Newcastle County. So people presenting with those concerns can be referred out to them. A late addition to the team was actually Planned Parenthood. We were discussing another research project with them, and we mentioned this one, and they indicated because of the array of services they can provide to especially women, they felt this fit their umbrella of need, and volunteered to come on a little late to the process, and they are part of our team as well. So that's the team. We're going to bring this group of people together, and we're going to implement this modified NIATEX change team process. And some of the activities we have there in the circle in the center there, we do brainstorming activities where folks at a table throw out ideas, and we have discussions about how to achieve our goal. We will conduct a series of walkthroughs at each of the individual organizations that's participating. As participants in the walkthrough will be people from agencies, people from our center, and the health practitioner who's going to be placed on site. And what we will do is visit each of those agencies or organizations and go through the actual, how do you enroll? What is required? What do you need to bring? What services can be provided there? How do you get there? All of those types of things we do through the walkthrough. We found these tremendously helpful in past work as members of different organizations get to visit organizations that they're less familiar with and go through that process is a tremendous learning process, and it enables the team to understand the service delivery procedures as the client experiences it, so that when we refer people out to these agencies, everybody on the team, when they're trying to remove barriers to linkage, having gone through the process as somebody showing up for services, is a very insightful way of determining where those barriers lie and how things can be changed. The team itself will decide upon what we will be screening on, the different conditions that will be screened on in the Delaware Probation Department. Again, the change team method is not the university comes in and tells people necessarily we want to screen on this, and this is how we're going to do it. It allows the team to kind of feel their way and make those decisions themselves. Once we have some of those things set up, we'll be designing what we're calling the Healthier You workbook, which is an interactive workbook, or will be an interactive workbook, designed to be given to people on probation, specifically written towards that audience, that will address a number of health-related concerns and other concerns, housing, transportation, all of those kind of things, and what services are available in the local area and how to access those services. Again, all with input from the walkthroughs and the other things that we've done. Once we have done that, we will begin the screening and referral process, which will essentially place somebody in the Newcastle County probation officers and begin referring out. And the same agencies on the right are the ones that are on the left. Those are the folks that we will be referring to. So the research part of this is really in 2 pieces. there is a process evaluation of the change team itself. So we don't have the way the study is designed. There's not a large enough sample of sites to really do a methodology, a rigorous study of the impact of the change team, because we don't have multiple change teams. We only have the one. But what we will be doing is a process evaluation, them largely qualitative. We will examine the process to identify facilitators and barriers, what worked, what was difficult in the process, what did people think about it. We'll be doing surveys with change team members on attitudes, opinions on the process. We'll be collecting those at a number of times throughout the studies. In order to determine we can do this, how much effort is involved, we're going to ask people on the team to kind of fill out a little chart of how much time they're spending on email, phone, in-person meetings, those types of things. We'll be doing qualitative interviews with the change team members at baseline 3 and 6 months during the change team process. And we will, of course, we'll have a graduate student there that's going to be writing, keeping minutes and taking notes on just kind of everything that's happening in the meetings and what's going on, so that at the end of it, we have a pretty good idea of what happened, what worked, kind of the, if you try this at home, be aware of these things, type of things that we can provide back to folks. So the other piece of it is the randomized trial that we have kind of built into the study, and what that part is, we essentially have two conditions. We have the health practitioner who will be on site conducting free health screenings at the Delaware Probation Office in Newcastle, and then providing linkage to service as a result of those screenings. The other condition in the study is that we will just be giving people the workbook, the Healthier You workbook, that will have information on different health concerns, where you can go to get help, and how to go about doing that. So we'll be giving one condition, we'll get the workbook. The other condition, we'll get the appointment. Well, not really an appointment, because we're going to do them in real time when we're up there. But to meet with the health screener to determine which is better at linking people to services. So the hypothesis there is screening and linkage of probationers by an on-site practitioner will lead to a greater proportion of probationers accessing services compared to those receiving an interactive workbook. And the null, of course, is the opposite. Screening and linkage of probationers by an on-site practitioner will not lead to a greater proportion of probationers accessing services compared to those receiving an interactive workbook. And so we want to see if the on-site health practitioner does a better job. Intuitively, I think that should work. But one of the things we want to see is whether we need to go to that length, because for an agency to do this type of work, if somebody tried this somewhere else, putting an on-site practitioner in a probation office to conduct screenings on a regular basis is an expensive and time-consuming thing to do. It is beyond the purview of probation. So they would probably not be doing it themselves, but to have another agency come in and do that for a probation department would be quite expensive. So we want to see, is it enough to make people aware that these services are available and that they can access them, and here's how to do it, to see whether those two conditions differ. So that's kind of what we're looking to do here. To do that, we've got a randomized design that we're going to put in place. We're going to randomly assign 400 people to one of each of those conditions, 200 in each group. Condition 1 and condition are there. I talked about them in the hypothesis. The data for this is largely going to come from electronic health and Medicaid records. And remember, we're looking at linkage to service, which is really, did you present at the hospital or at a service provider that was recommended either by the screening or if you got a workbook given to you on a particular day, did you then show up? And we'll be able to track that through electronic records. If a person is on Medicaid, we will be able to get the Medicaid records. Delaware has, the University of Delaware has access through another research project to all of the state medical records, not medical records, but Medicaid records in Delaware. So if a person is on Medicaid, we are able to access those records. As part of handing out the books or doing the on-site screening, we're going to develop a short screener form that will also have HIPAA waiver for that. Although people are telling me I don't need the HIPAA waiver for the Medicaid stuff because it's research-based, but we're going to do it anyway. And so we will have access to that. We've already talked to the participating organizations, and they have mechanisms in place where they can tell if somebody referred to them was one of the persons involved in the study. So we'll be able to get the large majority of the data essentially electronically. So for the majority of the sample, that's how we'll be able to do it. We are going to do face-to-face interviews with 80 of the folks, 40 in each of the conditions. We will be conducting those at baseline and then at 90 days after. And the reason for those is to determine whether there were barriers, what they thought of the overall process, and to try to learn more about ways to better do this in the future. We're still working out the details of the randomization. There's a couple of ways this can be approached. One is to randomize people on site at the office where somebody is there and people agree that they would like to participate, and we randomize them to either get a workbook or see the health screener. We're involved in another research study that has found that to be sometimes problematic because you're offering something to people and you're offering things to one group necessarily and not the other, and that may be something that people want, the free health screening. So another way to do this to prevent kind of confusion in the waiting room at the probation office is to select random days. So we would randomly show up on particular days at the probation office, and everybody in the office on that particular day would have access to either the workbook or a health screening by the health practitioner. So those are things that we're working out as we're beginning the research project and putting that kind of stuff in place. So in sum, what we're looking at is can a local change team increase healthcare provision among probationers? So we're going to implement a change team of a large number of agencies to improve the alignment and coordination of care to this hard-to-reach population. So we've got these representatives from 9 agencies to provide health screening and linkage. The team is going to create an interactive workbook for probationers, and a health practitioner will be placed on site, and we will conduct a randomized trial to see whether the on-site screening and referral links more persons to care. My last slide here is our timeline. We are in phase 1, which is July and August. We're just getting warmed up. We're getting IRBs and approvals in place. We've got the first one. We need to do a supplement on that. We've had our orientation meeting with the agencies, and we will be kicking off that team in phase 2 in September. So we'll begin the change team process and really work through the things I've been talking about there. That's going to take about 9 months, we anticipate. So sometime around May of 2017, we will begin putting doing the implementation where we will put the practitioner in the office and begin the trial. And then that will last for pretty much the rest of 2017. And then in the spring of 2018, we'll be doing evaluation and analysis and working on the sustainability of the program. If it determines this works, we will task the team or see if the team is desirable of keeping it and tasking them with determine a way that might be done. So that's what we're doing here in Delaware. And I think I might have run a little bit over, so I want to leave some time for Michael and for questions. So I'll quiet down and turn it back over. Thank you.
Fantastic. Thank you very much. This is just a tremendous project here, and I'm sure we'll have lots of fruitful discussion here in a moment. But we want to first give a chance to hear from our expert commentator today. We're very privileged to have Dr. Michael Shafer with us today. Again, he's a professor in the School of Social Work in the College of Public Service and Community Solutions at ASU and directs the Center for Applied Behavioral Health Policy at Arizona State University. And especially relevant to the S4A program, as I mentioned earlier, is the leader of the Collaborating Research Center for the SRA program that's based at ASU. So I will turn it over to Dr. Shafer to give some opening comments and thoughts.
Thank you, Glenn. It's a pleasure to be with you today and wonderful to hear about the exciting work that our colleagues at the University of Delaware are pursuing here under the mantle of culture of health. Drs. OConnell and Visher have targeted a uniquely challenging population to study the process of multi-systems approaches to health, those individuals involved in the criminal justice system in general, and those individuals under probation supervision in particular. As Dr. OConnell noted, we actually know very little about the health status and access to health care of individuals who are involved in the criminal justice population. Much of what we do know is focused on the areas of substance use disorders, mental illness, and HIV/AIDS, owing in large measure to our country's maligned war on drugs and what Fuller-Torrey and others have characterized as the criminalization of mental illness. However, if we extrapolate from what we know of the population in general that is involved in the criminal justice systems, we can arrive at some pretty disturbing conclusions. We know that individuals who are involved in the criminal justice systems, either in institutional or community correctional settings, such as those studied here, are disproportionately people of color, disproportionately individuals from the lower band of our socioeconomic strata, and tend to be targeted in zip codes and communities that we know from other work experience significantly lower rates of access to health care in general, and as a result, higher rates of chronic and acute illnesses, many beyond those that we typically ascribe to this population, mental illness and substance abuse. Impediments to accessing health care and other special services often put in place for individuals with criminal justice backgrounds, such as drug convictions and felony convictions. So one of the things I'm particularly intrigued with here is attendance to policy impediments that the multi-systems partners may inadvertently have in place that limit access to health and social services. Attitudinal barriers that people who are involved in the criminal justice system have that I think many in our general population might have, that these individuals are not deserving of public assistance, also create special impediments for individuals who have a criminal background. The focus of the current study is therefore intriguing, timely, and important. I think everybody recognizes people in the criminal justice systems draw upon multiple systems, and as Dr. OConnell has pointed out, those systems are often siloed and don't speak to one another. Simply connecting them, however, will not result in any significant changes in collaboration without targeted, specific interventions, such as the local change team model that Dan describes here. That intervention has to address some of the organizational and personal values and bias that systems and the individuals working within those systems may have toward individuals with a criminal background. Organizational culture and simple things such as organizational language. The C.J. Dett's study that Dan had referenced before, where we had collaborated, one of the things we were struck with in working between addiction treatment providers and criminal justice systems was simply the language used to describe the same client or individual, offender versus client. It may seem like a small thing, but it is really the tip of the iceberg of the larger ethos with which organizations approach the work that they do with individuals. And then lastly, specific interventions that address the organizational policies and the resulting procedures in queuing individuals, eligibility procedures, etc. While OConnell and Visher here describe the use of a modified NIATEX model, I would suggest the model described draws upon systems change models that actually predate NIATEX by 15 to 20 years, and in many ways are much more robust than NIATEX. Michael Benz and Andrew Halpern, for example, at the University of Oregon, launched the Community Transition Team model in the late 1980s, targeting the transition of special education students as they age out of special education systems and enter the world of adult services, including developmental disabilities, vocational rehabilitation, and housing. Again, this issue of multi-system sectors, alignment of policies, of eligibility, of service provision, and queuing of patients become much more complicated. While OConnell and Visher, and indeed the work that had been done under C.J. Datz, borrow elements of NIATEX, NIATEX actually appropriated from others. The significant difference between what Dr. OConnell is describing here and what Dr. Gustafson and his colleagues had characterized under NIATEX is indeed this multi-systems and interagency approach, significantly complicating the process beyond the single system of addiction treatment that NIATEX had focused on. Dan indeed has 9 executive sponsors to deal with, not simply one. He's got 9 agency walkthroughs to facilitate in his change team, not simply one. And then the integration of those walkthroughs into a comprehensive understanding of each system and where the bottlenecks and where the points of connection could be extrapolated. So I'm very excited to see the work that's being done here. My issues, I guess, or questions that I might have here really have 4 that I'll bring to the attention. One is the necessity, I guess, or the robustness of a randomized design model here. And actually, Dan, you provided greater clarification of what was being randomized than what I had seen in the slides before. And I think you speak to one of your potential threats to your internal validity here is going to be a potential for spillover and spread effects, disproportionate issues among your control sample. Second, I was intrigued with the identification of the correctional head as your executive sponsor. As I understand NIATEX and understand kind of our work in this area, each of the agency heads for each of the collaborating agencies have got to have executive ownership. And one of the things I always appreciated when I heard and have read the work from NIATEX is that change team member or change team members have a direct pipeline to the executive leader in the agency, the CEO for the agency, et cetera. So each of those 9 agencies have got to own the process and empower the members of their staff who are participating on the change team. Third, curious to noodle down a little bit more on your theory of change. In your closing slide, you speak to alignment, cohesion, and synergy. And it strikes me that while your primary outcome measure is Medicaid expenditures, if I understood it correctly, I think there are important, more immediate and proximal effects in terms of interagency culture, collaboration, communication, and cohesion. You speak to your qualitative interviews, et cetera. Didn't know if there were any standardized measures around collaboration across your change team members. obviously, I think a great area for social network, interagency network of work. Finally, in that area of theory of change, I want to come back to this issue of policy scan and policy impediments and barriers. I know some of the issues we face here in Arizona and elsewhere in the country are the unintended consequences of initiatives by local law enforcement, for example, around crime-free housing, which then creates impediments to accessing subsidized housing, barriers for individuals with felony convictions to service access, such as access perhaps to financial aid on the educational aspect. And then the last comment or question is curiosity about where your health exchange and state Medicaid eligibility is. I'm intrigued with the use of the health screener in the jail. Here in Arizona, they've taken a very similar approach following up from the passage of ACA. But rather than putting a health screener in place, they put an insurance screener in. So in our county jails here, we have health exchange navigators in the jail providing information to offenders about ACA, health exchange, Medicaid enrollment, and our county probation system has adapted their assessment protocol, their risk protocol, to also include an insurance screener and then linking probationers to navigators for insurance. I think the work you're doing here is exciting. I think it builds upon the work of C.J. Datz, and I think in the interest of the Robert Wood Johnson initiative of creating a culture of health really targets the real spirit of the initiative with a particularly challenging population.
Fantastic. Thank you so much. Thank you so much, Dr. Shafer. And I'm hearing a little bit of feedback, so we could, again, ask folks to mute their phone. Excellent. So that was an excellent commentary. We do have some time now for a little discussion. And I'm first going to invite our speakers to, if they want to respond to any of those last four kind of questions or comments that Michael gave to us. But before I turn it over to Daniel to respond to any of those, again, I want to invite you all to use the chat box to type in your questions or comments. We have a couple in there already that we'll get to in just a moment. Go ahead and try other questions that you may want to get on the table. Please use that chat box. And before I turn to that chat box, I'll give Daniel a chance to a minute or two to respond to any of those last comments from Dr. Shafer.
Thank you. Thank you. I appreciate that, and I appreciate Dr. Shafer providing us some commentary on this. If any of you know Dr. Shafer, his experience in these types of areas is long and deep. So having the opportunity for him to take a quick look at this is definitely we're thankful for that. I'm going to address very quickly the questions that he raised, and the first one was the threat of the spillover and spread effect in the trial. That's going to be a concern that we're going to have, because people coming to the office on a regular basis, they talk to each other for one thing. So we're going to have to do some observation in the room to try to head off that. It is something we are aware about it, and we will welcome any assistance and feedback we can on how to minimize that. We're hoping that because the main outcome is the linkage, that it won't be too great, and I think it's going to be more of a concern actually on our control condition than in our intervention condition. But those are threats to sampling like this and studies like this that we're aware of and are going to pay more attention to now, because if Dr. Shafer thought it was worth bringing up, then it's worth looking at. the 9 agency, it's both a concern and a benefit to try to do this with this many people, so we're both happy, but as you know, when you get a lot of people over the table, things can happen. Now, we may have some language issues with the organizational sponsor, executive sponsors. We do have the leaders of each of the agencies are aware of and involved in the studies. Each of them has an organizational sponsor who will be part of the team. So I might not have framed that exactly correctly. The executive sponsor, the chief among equals, if you will, is DOC because it's happening in their shop. And so I might not have been overly clear about that. Again, coming in number 3 on the outcomes in the agency culture and change, which actually addresses one of the questions we've got in the chat, what we're doing about culture here. Any cultural change that we're going to try to have and measure will be in those agencies as we get these agencies focusing on the offender population. And we will have some measures in. We've got it kind of set up qualitatively for the change team, but we're early enough in the game that we may be able to add some items to get in there to make sure that we are capturing any of that both at baseline and then see if that changes. If we can do some change in that culture, partly by bringing the agencies together and partly by having them focus on something that they traditionally do not focus on, and that is the healthcare of probationers. Policy changes, we're hoping to see some actually, because we know Michael mentioned the felony restrictions on many things like housing and access to services that are based on criminal convictions, many of which are, again, resulting from drug war kind of things. So that we're hoping that by bringing this group together, addressing these kind of things from a health standpoint, maybe we can see some change on that. Michael referenced, this was not one of his question so much as something that they're doing in Arizona, where they're screening in jail, and they have health navigators working with probation and insurance navigators. The insurance will be part of the screen. One of the things we were happy to find out from Christiana Care, our medical provider in this study, is that they have what they call health navigators in their institutions, whose job it is to do exactly what Dr. Shafer was talking about, dealing with those insurance issues and that kind of stuff. So they are part of the team. The thing is, they're on the linked edge. That they are at Christiana Hospital. So one of the challenges of the team would be to perhaps see how we can take some of that framework. I doubt they're going to want to put somebody on site, but to do some of that navigation upstream with the health provider that will be in the institutions. So I know we're running out of time, so I will turn it back over and then listen for anything else that folks may have. Thank you very much.
Fantastic, and thank you, Daniel, for expertly addressing those comments raised by Dr. Shafer. And in so doing, you also answered the question from raised in our chat box by Dr. Bill Riley about the issue of how you affect cultural change, and also I think how you measure impact on culture as well. I might just, in our closing minutes here, just pick up on that theme as well. I know this issue of how we measure change in culture is something that the collaborating research centers, all 3 of them, together with the National Coordinating Center, are thinking about and pondering in regard to the collaborative study that our 3 collaborating research centers will be conducting together. And one of the areas that we're beginning to explore is this idea of looking at goal alignment as a signal of culture change, especially multisectoral culture change toward alignment and integration. And as part of that, we're exploring some of the methods for how you measure goal alignment across sectors and across agencies, and as a potential kind of more proximate outcome measure for this kind of alignment work that, as Dr. Shafer was was referencing. So stay tuned if you're interested in that kind of approach of goal alignment as a potential signal for cultural change and integration, because we're hoping to make some progress on that and hoping to present on that in a future iteration of this Research in Progress webinar. So again, thank you. We are at time, so we'll go ahead and close out today. Thank you again to our speakers. This is an excellent example of the value of presenting early on in the phase of research execution. We heard about design and research plans today from our colleagues at Delaware. You're seeing how this kind of discussion can shape how research gets implemented and be informed by commentators and collaborators as part of the program. Please put on your calendars our future webinars. You're going to hear more from other projects, others of our individual research projects that have been funded through the S4A program. You can see the upcoming webinars here from our other 3 individual research projects in S4A. We'll also be hearing from, in future iterations, hearing from presentations from our collaborating research centers, presentations from some of the research that we're conducting here at University of Kentucky in the National Coordinating Center on this front. So please make this a regular part of your research activities. We do these about twice a month now as a way to share findings and share information and strategies in the F4A program. Thank you again to our speaker and thanks to our commentator. Thanks to all of you for joining us, and we'll look forward to hearing from you soon. So long.